Thank you very much. I hope it works. Yes, it's really a pleasure for me, and I thank you for your invitation. You see in the title of this introduction to the discussion we will have that I have to speak of two problems. Patients' non-adherence. They don't do what we ask them to do. And doctors' clinical inertia. We doctors, we don't do what the health authorities ask us to do. And you see that you may see already an homology between the two phenomena. And the core of my talk, of this introduction, will be to try to convince you that these are two manifestations of what I will call medical irrationality. These are my disclosures. Actually, I have no disclosures for this topic. So the first point, I think it's very important that all of us appreciate the frequency of the two phenomena, patients' non-adherence and doctors' clinical inertia, under real-life conditions and their consequences. This is a representation of ideal care. So you see, this lady gets a disease, she will go to a doctor, the doctor will have a diagnosis, they will decide together a treatment, the doctor will make a prescription, he will give this prescription to the patient will follow this prescription, and everything will be fine. Unfortunately, it is not so simple. And from time to time, you have what we call patient non-compliance. Now, Sylvia, you are perfectly right. Better, non-adherence or maybe concordance. We don't have this. And therefore, she does not follow the therapy. And there is no improvement in her condition. And this is a classical definition of compliance. The concordance between the patient's behavior, for example, taking medicines or following a diet, and the prescribed therapy. It's very frequent. There is a way to assess adherence. It is just to count the number of boxes of pills that the patients buy. And if you know how many boxes of pills were prescribed, a simple ratio can give you an estimation of patient adherence. And you would be happy if this ratio is higher than 80%. And you see, the patients don't do that bad. For instance, in the field of hypertension, 72% have this index higher than 80% and can be considered as adherent. But you see, for diabetes, only 65%. For gout, the worst, 36%. And this has obvious consequences. For instance, if you have here, you see the glycated hemoglobin as a function of this ratio, if the ratio is higher than 1, all what was prescribed was bought. In that case, glycated hemoglobin is less than 7%. And you see this nice negative correlation. This may mean that actually a large part of our problem is related to adherence. Of course, this has consequences. And you can see a number of papers demonstrating, for instance, here in a multivariate analysis, showing that non-adherence remains significantly associated with increased risk for all-cause hospitalization. And of course, this has consequences in terms of cost and for all-cause mortality. On the contrary, adherence to diabetes therapy was found to be associated with a decrease in healthcare costs, mostly through a decrease in hospitalization. Interesting paper. There may be a very vicious circle. You see, poor medication adherence, poor health outcomes, increased service utilization, increase healthcare costs. But in those countries where patients have to pay for their costs, when the cost is passed on to patients, this will increase medication adherence, and you have a vicious circle. And in this paper, they mention that 100 billions to 300 billions of avoidable healthcare costs have been attributed to non-adherence in the US, and Sylvia gave us also very impressive numbers. So this was the first barrier. But now you have a second barrier, which is not here at the patient level, but that is at our levels. And this is what is called clinical inertia. Here there is no prescription. And of course, if there is no prescription, there will be no therapy. And if there is no therapy, there will be no improvement. And this very strange phenomenon was really described as such in this seminal paper by Lawrence Phillips 15 years ago now. It's interesting to read what he said. The goals for management are well defined. Effective therapies are widely available, and practice guidelines for each of these diseases have been disseminated extensively. Despite such advances, healthcare providers often do not initiate or intensify therapy appropriately during visits of patients with these problems. We define such behavior as clinical inertia, recognition of the problem but failure to act. There is a very recent paper published this week in Diabetes Care. And you see these are newly diagnosed type 2 diabetic patients who fail metformin monotherapy, no control. And you see, if you take as a definition of poor glycemic control, glycated hemoglobin higher than 7%, treatment will be intensified early in only 62%. So in 38% there was no intensification, early intensification. And of course, this has consequences. This is now an old paper by Brown, but what she said, you see here, suppose that these are months, and these dots here are your visits. And here, glycated hemoglobin increase from 7.5. You think here you are safe, but here 8.5. Of course, here you consider that this is not good for the health of the patient, but what can you do? But here now, suppose that here the patient remains with high glycated hemoglobin. This is what she called avoidable glycemic burden. This is unavoidable, but this could be avoided. And this is an important paper, and I think you recognize the data of this paper by Paul. A large number of patients of patients with 7.1% had at least one cardiovascular event. And you see that a 1-year delay in receiving intensified therapy was associated with significantly increased risk for myocardial infarction, stroke, heart failure, or a composite cardiovascular event index. So you see, this is an important step. This was a brochure published by the WHO now a long time ago, 13 years ago, and WHO claimed that increasing the effectiveness of adherence interventions, this was adherence for patients, may have a far greater impact on the health of the population than any improvement in specific medical treatment. So stating that patient adherence is a huge issue, a huge barrier to the efficiency of care. I think that actually there are two barriers to the efficiency of care, not only patients' non-adherence, but also our own non-adherence to a good clinical practice. So, how to explain these two phenomena? And since I put them together, I think that it's interesting to try to examine whether there are not common mechanisms to the behavior of the doctor and the behavior of the patient. First, maybe the relationship we have to time, care and time. first point that we, both of us, we don't have enough time to care. Interesting publication, 10 years ago already, showing the time spent by patients for their treatment, for their daily care. 58 minutes per day as a mean. But you see, what is interesting? It is that if you consider the adherence to self-blood glucose monitoring, the patients who never test blood glucose, they spend less time to their general care than patients who do better the self. So this may mean that it is a whole. You see, if you do some things, you will do the other things. For instance, food care, exercise, and so on. This was the side of the patient, but now the doctor's side. A major cause for what is called clinical inertia is a lack of time. You see, for instance, here, if you have long visits, longer than 20 minutes, you will have more chance to intensify therapy than if you have very short visits. And we should think to the time spent by general practitioners with their patients. But there was in this paper another point which was shown. If the patient comes with another problem, what they called a competing demand, an intercurrent event, in that case you see that this decreased dramatically the percentage of change in medication. So this highlights the effect of time. But when I said that there is a problem of our relationship to time, to temporality, I would like to propose to you another point. The preference for immediacy. We have a tendency to give the priority to the present and not to the long term. And I try to illustrate this with the problem of acceptance of insulin. You know, she knows that she should accept insulin to protect her future, but immediately she is afraid of hypo weight gain. This is the future, this is the present. I know that I should prescribe insulin. This is what the guidelines tell to me. But I think immediately, she will refuse. And I don't propose insulin. You know, this terrible paper by Wallace and Matthews, look at the title, Poor Glycemic Control in Type 2 Diabetes, a Conspiracy of Disease, Suboptimal Therapy and Attitude. What they wrote, patients and physicians often collude in implicit and unspoken contracts to continue oral agents for as long as possible. You see how the two aspects of patient non-adherence or patient insulin resistance, psychological insulin resistance, and the behavior of the doctor, they can go hand in hand. And of course, if I don't propose insulin, she will say, so it was not so severe. So you see that my behavior will increase her denial of the severity of the situation. But actually, I would like to propose to you that there is a more profound, a deeper reason to all these problems. And I would like to try to identify a more general cause and the contrast between the logic of evidence-based medicine and what I will refer to as the complex thought of patients and doctors. This is the logic of evidence-based medicine taken from this super paper by Haynes and Haynes. You see, everything starts from the randomized control trials on large populations of patients. And here, the analysis of this data will lead experts to propose guidelines. This will be the evidence to the doctor. And the doctor has a patient in front of him, and he has to take into account the patient's circumstances and the patient's wishes. So it looks very nice. But you know, very early, after the first guidelines were published, one realized that there was a gap between these guidelines and what doctors did under real life conditions. And you see, for instance, do practice guidelines guide practice. And these papers, this was actually published before, long before the publication by Phillips in 2001. You see, very early, one realized that there was a problem. So if I try to go back in depth in the principle of evidence-based medicine, I think that it can be characterized as driven by a technical rationality. And actually, it is a science. Medicine becomes a science, and the aim is to describe reality as objectively as possible. And the method will be to use large clinical trials, eliminating subjects, that is, their variability and their subjectivity. And so a clinical trial, as you know, uses a procedure which is called randomization, and you will generate from this crowd of people two groups of persons. And it is beautiful because, for instance, this is a clinical trial, and these people were given placebo, and this one 2 doses of medication. This is why you have twice more patients here than here. But you see that the age, for instance, is exactly identical. When you look at that, it's superb. 63.1 year. Exactly the same. And you know that when you read a trial in the New England Journal of Medicine, the first thing you will do, will make sure that there is never P below 0.05, because this would be a problem. But due to the virtue of randomization, this never happens, or almost never. So that's superb. And you get this kind of curves. I think that you recognize. I did not put the name of the medication because I wanted to avoid entering the disclosure problems, conflict of interest, and so on. So, but you see that here, obviously, the medication has a very strong effect in decreasing cardiovascular events. Superb. This is a triumph of science. And you see that evidence-based medicine generated knowledge. But now the problem, this is the epistemic part of evidence-based medicine, not the praxis part of it. And when we will use guidelines, we leave the knowledge to arrive in action, and here there may be problems. Because you see, here we have the average patients. They don't exist, actually, but I have in front of me my patient. This is a patient of mine, yes. And what about for this patient? The type of symptoms, the evolution of disease, the existence and severity of comorbidities, previous experience with the medication, the patient's psychological profile, the patient's adherence, the patient's wishes. This is taken from this a very important paper by Finstein. And you see, we can say that there is some kind of simplicity in the basic principle of evidence-based medicine, which is different of the complexity of the mind of the patient and of the doctor. Randomized control trial, simplicity. The aim is to answer one question. There are inclusion and exclusion criteria. There are patient cohorts. And you will compare two groups of average patients. But here, complexity. The aim is not to answer a question. The aim is care. There are no inclusion criteria. No exclusion criteria also. You cannot say to the patient, sorry, you don't belong, I cannot take care of you because you are not in the inclusion criteria. So, and the patient does not ask one question. He asks several questions. Actually, he does not ask questions. There is a situation and a context, and you take care of an individual patient, my patient, she. I advise you to read this book by Donald Schoen, The Reflective Practitioner, How Professionals Think in Action. Randomized control trial, simplicity. The aim is to answer a question by a technical rationality stemmed from positivism. From the moment a problem is formulated, it can be solved by a statistical approach. It is exactly the principle of evidence-based medicine. But under real life, the main issue is not solving, but formulating the problem for each individual patient, because the patient does not ask a question. And you see what Donald Schoen said. In real-world practice, problems do not present themselves to the practitioner as givens. They must be constructed from the materials of problematic situations which are puzzling, troubling, and uncertain. And the true question, to try to understand the issues of patients' non-adherence and doctors' clinical inertia, is to ask, how do you reason, you doctors? How does your patient reason? You know, first, there is an interesting paper. I like very much this paper because he proposed the terms of mind lines, not guidelines, but mind lines, the mind of the doctor. And you see that in his mind or her mind, of course, there are the guidelines, but there are a number of other elements that he or she takes in consideration, including the patient's view, and with exchange here. We have our reasons, and reasons are not only rational. I would like to propose to you to make a small test. Suppose that I got credit for that. If you decide A, you will leave this room with 450 euros. Thank you, Lynn, for the grant. Huh? But if you decide B, 50% of chance to win 1,000 euros, but 50% chance to win nothing. Who would prefer A and who prefer B? First A. Here you are sure. Leaving this was okay, I see that most of you prefer A. You are wrong. I will tell you why. Because you are not rational. Because if you were rational, you should make what is called a calculation of expected utility, where you multiply the probability by the value, and you see that here you have for A 450 and here 500, so you should prefer B. So actually the things are not so simple, because now if I tell you, you have to decide between here A and B. A, you will lose your, how do you say, portefeuille, where you had your money, you know. You lose it in the street. A, sure, you will lose 450 euros, which were your portefeuille. But B, 50% chance of losing it. And now most of the people prefer B. You see, that's strange. So that means that actually our mind is complex. And this kind of complexity was described in detail by Daniel Kahneman and Amos Tversky in what they described as a prospect theory, published here, you know, a long time ago, and where they showed that if you consider gain or losses, the psychological value you will give to gaining 100 euros is less than the negative psychological value if you lose 100 euros. And this loss aversion expresses the intuition that a loss of 100 euros is more aversive than a gain of 100 euros is attractive. I would like to mention that Daniel Kahneman got the Nobel Prize for Economy for this very important concept, because it is useful for a number of things, and I would propose that it is relevant for the issue of patients' non-adherence and doctors' clinical inertia. For instance, you or our patients, both of us are human beings. We may give more importance to the fear of side effects than to the benefits of treatment. Daniel Kahneman published this book. I really advise you to read this book. It is a fascinating book. All the studies he made with the late Amos Tversky. And he described how we reason. We use either a system one, and most of the time, a system one, which is fast, automatic, uncontrolled, that use heuristics, that is very simple, fast, efficient mental procedures that help find adequate, though often imperfect answers to difficult questions, and that is effortless. And not the system two, which is slow, reflective, controlled, analytic, and cognitively demanding. Other point, both of us, we have emotions. Now the emotions in the doctor's side. I would like to give an example. Prescribing warfarin in people with atrial fibrillation. If I do this, there may be a risk, bleeding. If I don't do it, clinical inertia, omission, there is a risk, stroke. What do I prefer? That my patient has a bleeding due to my prescription or a stroke due to her disease? You see, that's human, Sylvia. And this was analyzed in this very nice paper published in the BMG 10 years ago, where they looked at of general practitioners. They had one patient who experienced bleeding, and you see that in the year after this event, the doctors decreased their prescription of warfarin, and this was significant. The study was very well done. There was a control group with ACE inhibitor, no effect. And now, if one of the patients had a stroke, they increased a little bit their prescription of warfarin, but it was not significant. I would like to show you the effect of emotions in patients. This is a study we did a long time ago. We got from our patients page of their logbooks, and we know what they really did. And we copied the numbers, but we removed the insulin dose, and we gave them back the blood glucose values without the insulin dose and asked them what they would do as a theoretical exercise. And we also gave the logbooks to 6 experienced diabetologists. Experienced diabetologists, I was one of these experienced diabetologists. And here are the results. And you see, if you look at the augmentation of insulin dose, we doctors, we propose augmentation of insulin dose very frequently, I think because we are not at all afraid by hypoglycemia. But patients did do it less. But what was interesting is that as a theoretical exercise, a rational exercise, they would augment more frequently insulin dose than what they did under real life conditions. And this was highly significant. So you see, emotions are part of our mental life, and we should not blame emotions. I don't know if you realize that there is more emotion after just missing your train by a few minutes than after missing it by 30 minutes. You know, you arrive to the railway station and you see you are furious. And it is very important that you feel furious, because this will be a lesson. So next time we will not miss your train. And you see that we have to consider that emotions, this may be the toll to pay, there is a toll to pay for their presence in our mental life. Non-adherence and clinical inertia, the fear of side effects. And there are no emotions in evidence-based medicine. I found this very nice qualitative study, and this is one of the verbatims of the doctors. The doctors say, "As I saw the panic rise in her eyes, evidence-based medicine went out of the door, and reassurance was what was needed, because there was very little one could do about her, and I could see her husband pleading behind, 'Stop talking science and start talking something else.' So I patted her on the hand and told her all was well and it would get better in a little while." So just a few slides to finish this introduction. How to solve this problem? I think that the individualized target is a first step. Very important, because you see, we leave generalized guidelines to individualized guidelines. And you recognize what has been published by Ismail Beji and then taken by the American European consensus. We could take care of this patient and not average patients who do not exist actually. But nothing new. It was always said. Look, 1996, Sackett, evidence-based medicine, what it is and what it is not. Evidence-based medicine is a conscientious, explicit and judicious use of current best evidence in making decisions about the care of individual patients. It was said, but maybe we forgot it. Or here, look, the evidence, yes, but the patient. So this is important to go to individualized medicine, but this is only personalized medicine. I think this is not enough, and I think that we should go to a next step, which will not be personalized medicine, but person-centered medicine. And what I would like to propose to you is to define person-centered medicine as the approach that takes into account the complex thought of doctors and patients. And this was beautifully said by Sir William Osler, you see, in 1907. Our work is an incessant collection of evidence, weighing of evidence, and judging upon the evidence. It's strange that Osler spoke about evidence and a long time before the concept of evidence-based medicine was coined. And we have to learn early to make large allowance for our own frailty and still larger for the weaknesses, often involuntary, of our patients. And this will be my conclusion, the need for person-centered medicine. If, I hope that I convince you that, patients' non-adherence and doctors' clinical inertia are the consequences of the contrast between the technical rationality of evidence-based medicine and the complex thought of patients and doctors, then patient-centered care, taking into account this complexity, may represent a general key to avoid them, and this has obvious implications for the teaching of medicine. Thank you.